And with that, I'll turn it over to our facilitator, David Hughes, who is an associate professor of surgery. Thank you.
Thank you, Laura. Thanks for joining us, everyone. I want to thank Molly Chusty for organizing everything. She's been a great help over the past couple of days getting this all organized. And thanks to Laura for setting up another great session for medical education. I really enjoyed Meg's talk. I learned a lot about coaching, and she gave me a plug about my talk, which is about feedback. I'm going to share my screen here. So just as a disclosure, I never really thought I'd be talking about feedback. I'm a clinical surgeon. I work in general surgery. My clinical specialty is endocrine surgery. I'm really interested in teaching medical students and residents. And I got into this feedback business about 5 years ago, which I'll talk about a lot today, basically because we had a problem in our surgery clerkship that we tried to fix. So this is a picture of David Agnew at the University of Pennsylvania. And I put this up there because this is not how we teach in medical education anymore. I can remember exactly 0 times where I was up in front of a bunch of medical students professing how to do surgery. Really just don't work like this anymore. So that's why I think it's really important to talk about how to give students and residents feedback. And I'll talk about some innovative ways that we've been doing that within the Department of Surgery. So I have no disclosures. I am going to talk about the 1-minute feedback system, which is a system we developed in the surgery department about 5 years back. That's now being turned into a standalone app. The University of Michigan owns this, and I have no financial stake in it at all. So why do we need to talk about feedback? Seems like feedback is a pretty easy thing to do. And I, as an educator, think we do it really every single day. We teach in a medical environment that's very different than it was, 10, 15, 50 years ago. Medical students and residents get taught by not just faculty, they get taught by nursing staff. Patients sometimes give them their own education, and feedback is really where this all happens on a day-to-day basis. The majority of teaching that students and residents get is that feedback about the performance of clinical skills that they do every day. It's not standardized tests, it's not standardized patients, it's not the lectures that we deliver to them. Really, it's the day-to-day things that they do every day. So the objectives of the talk today is to really talk about what feedback actually is. I think it's important to understand what we're talking about. Why is it so important in today's medical education environment, and why do we need to spend time talking about it? And why is it so hard to do? It seems like an easy prospect, but routinely when you ask students and residents if they've gotten enough feedback about the performance, they always say no. So we'll talk about why that is. We'll talk about some of the innovative feedback methods that we've created. I'll talk a lot about our experience with the 1-minute feedback system that we've created, and then some other work in the Department of Surgery with interoperative feedback, both with Simple, with work with Brian George, and then Dr. Gurjeet Sandhu, who might be on the call, has done some really cool research studies in feedback in the Department of Surgery. Then I'll lead us into a discussion about how we've created a culture of feedback in surgery, which I would posit is difficult. Many surgeons may not be known as the most kind of kind-hearted feedback type of people, but we're definitely making some changes. Now I want to leave about 20, 30 minutes at the end for discussion, because I really think that's the most important part about these sessions here. So what is feedback? Feedback is information or reactions to a product or a person's performance of a particular task. These things typically have to be monitored, and you as the person giving them feedback has to see them performing a task. It tends to be day-to-day, tends to be immediate, and it's really formative in its intent. I think a lot of people get feedback and evaluation confused, and I think a lot of our learners are really scared that they aren't getting enough feedback. So at the end of the rotation or their semi-annual evaluation, they're going to end up like all the other students that just got a passing grade on their clerkship or got some bad feedback only in the end of rotation evaluation. So really feedback, if it's done well, can help avoid this kind of surprise at the end of the clerkship rotation. So I think in medical education, we've used evaluations too frequently to provide feedback to our learners. And really, that's not what it's intended to do. Feedback is really intended to modify students' performance to achieve some desired goal, which is really tangible. How to do a physical exam for diabetes. How do you perform an appendectomy? These are very concrete things that we need to teach them how to do. And the feedback needs to be immediate. You need to see them do something, then you need to give them positive or negative reinforcement of what they did. And it needs to be very specific about things that they can do to change that action to improve it. Evaluation, on the other hand, has some type of standard ranking or judging that goes along with it. That could be a grade for the clerkship students. It could be a milestones assessment for our residents. Really, this is going to be delayed and comprehensive, and it requires multiple different people to weigh in on that student or that resident's performance. Like many of us, I read my evaluations that the students and residents give of me. I usually skip through all the Likert scales that they've given me and just focus in on the comments. And really are trying to dig out something that you can do to improve either your teaching, your clinical care, and really that's the meat of what the evaluations are intended to do. So I think a lot of times our students feel like they're adrift in the clinical environment and they really don't get any feedback about their performance. If we don't give them feedback, they have really, they're kind of lost in the clinical environment. They can make mistakes that really go uncorrected. They can do things well and not get positive reinforcement and keep doing those things later on. And if the students are really adrift in the clinical environment, them achieving the competencies and learning the things that you want them to learn just happens by chance. So really we want to give the students or the residents oars themselves so they can row themselves through the clinical environment. And then we need to teach them how to do that in a way that gives them positive feedback. So there's a lot of barriers to feedback, and I feel these every day, and I'm sure a lot of you do as well. There's so many competing priorities that we have as clinicians and as educators that we feel every day. I did clinic yesterday with a resident. We saw 22 patients. I think I gave the resident a lot of feedback about things, but the majority of our day was basically taking care of patients and doing what you need to do for their chief complaints. There's time constraints all throughout the clinical environment, and this is one of the main barriers to feedback. Some of us don't know how to give feedback. We've been taught how to be physicians, but we've never really been taught how to be really good educators. And there certainly is some things you need to know how to do to give good feedback. There's some hierarchical challenges both up and down the ladder. I've had a lot of faculty complain to me that they can't give students or residents negative feedback because they're scared that they're going to give bad evaluations of them, and that may interfere with their promotion or tenure. Then there's some peer deflation too. We live in an environment where we care about our students, we care about our residents. We don't really want to crush their souls with some negative feedback about the performance, but really that negative feedback and ways that we can give them actionable items to correct is really what they want and need. Even when we give them adequate feedback, there's a lot of problems with the feedback that we actually give them. Sometimes it's low volume, and I think the residents and the students complain of this most frequently, that they just don't get enough feedback throughout the day. And we'll talk about a little bit about the reasons for that. There could also be some poor quality feedback. Most of the feedback that I think a lot of us are used to giving is that good job, read more. You see these on the evaluations at the end of the rotations. Unless you really give them something specific to act on, that feedback is really lost on the learner. It needs to be timely as well. It needs to happen day to day, needs to happen in the moment. That's the best time to correct clinical procedures or performance of the students. And then it's not just us as faculty, it's really the students that need to take part in this as well. They need to reach out to faculty, to residents, ask for feedback, and ask for feedback that's relevant to them. So I'm going to tell you a story about the problem that we had in surgery, which kind of started some of our work with innovation. As the assistant clerkship director and Rishi Reddy, who was the clerkship director at the time, We would get these evaluations from students about their experience on the surgery clerkship. We were dead last compared to all the other clerkships in the students getting adequate amounts of feedback and feedback that was valuable to them. So the students were really unhappy. We, as clerkship directors, needed to fix this. We thought we gave great feedback. We taught all the time, and we were really surprised that the students really didn't feel that they were getting adequate feedback. So we basically came up with a solution that we thought could help fix the problem. We thought the real problem was the barriers to communication between the students and the faculty, and really wanted to create some kind of communication tool that not only allowed the students to get feedback from the residents and the faculty, but also allow us to measure it. So we created something called a minute feedback system. And really, this is just a communication tool between students and faculty with the goal of giving them extra feedback. So at the beginning of the rotation, the students would get an email. This email had a link to a survey. It was a Qualtrics survey that allowed the students to open it up. When they open up the survey, they would select which faculty they worked with during the day, how long they worked with the faculty, and they needed to ask something that they wanted feedback about. This could be physical exam. This could be, technical skills with suturing in the operating room. Really could be anything at all. Very brief, took them about 20 seconds to fill this out. Once they submitted this survey, it would immediately send an email to the faculty or resident. They would open up the link and it would say, this student worked with you during the day. They want some feedback about their technical skills. There's a free text box. The faculty or resident would fill in that box with a sentence or two. Should take less than a minute. That's why we called it the minute feedback system. They would submit it. It would immediately go back to the student and they would get their feedback. Pretty simple, just a communication tool between the residents and the faculty. This is a little bit more detailed version of what the students saw. This went through many iterations. We settled on this one because it required the student to specifically say what they wanted some feedback about, which we thought was really important. And this is the view of the faculty version of it. There's no grading associated with it. There's no ranking. It's purely just formative feedback for the student. The other part of the feedback system, it allowed us as the clerkship directors to monitor this, and it allowed us to meet with the students halfway through the rotation and review all the feedback comments that they got from all the different faculty members. We also fed it back to the rotation faculty leads, just to get an idea of how the students were interacting with the faculty and which faculty were interacting with the students. We tried it for about 2 months on some of the surgery services. We used 2 services that had access to it and all the other services didn't. Then we asked the students whether they felt the frequency of feedback, the quality of feedback, and then the overall rating of the clerkship was better or worse with the minute feedback system. There was notable improvement on the services that use the feedback system. So we thought we had fixed the problem. We decided to roll it out to all the different surgery services. It actually took off pretty well. Over the first year of work, it was used over 2,000 times by students. The faculty response rate was around 60%. And then when we asked the students whether they got enough feedback during the rotation, about 80% of them said yes. So we had a pretty drastic improvement in the students' experience on the surgery clerkship. We also felt the faculty could improve things because it allowed them to fill out their evaluations quicker. At the end of the rotation, we allowed the faculty to see their own feedback comments about each one of the students. So it made it a little bit easier for them to fill out the evaluations at the end of the rotation. So we thought we had something that worked out pretty well. It addressed an issue that the students had, but it also gave us a lot of data about this feedback interaction between the students and the resident, or students and the residents and the faculty. It allowed us to track how often the students used it, so you could tell which students were engaged with asking for feedback and which ones weren't. It allowed us to figure out what they actually asked for feedback on. Surprisingly enough, most of the students fell into the trap that they just asked for general feedback. Just like a lot of the faculty that only give general feedback to the students really never ask for something specific. It allowed us also to track some LCGME requirements. We used it to track direct observation. So the students on the clerkship need to be observed doing a physical exam and a patient history. So the feedback system allowed us to track that. The faculty also allowed us, we also were able to track faculty use with both the response rates and the overall content and the quality of the feedback. We could see what they're actually telling the students when they ask for feedback. We had lots of data in the years that we've been using this. It's been used over 10,000 times by the students to get feedback. So with this database, it allows us to do a little bit of research, diving a little bit more to what feedback is actually given to the students. So this was a research project that Gabrielle Shaughness, who was a third-year medical student at the time, did with some of the surgery residents, looking at just the feedback content that was in the feedback system. So over the course of a year, there was around 3,000 feedback requests from our medical students while they rotated on surgery. There was about a 62% response rate, which means about 2,000 faculty or residents responded to the students. What Gabrielle did is she classified all the different feedback comments to the students into 4 broad categories. There was encouraging feedback, which basically commended the performance of a particular task. And there was corrective feedback that suggested they need to make some modification to what the student did. Then there was either specific comments where it's commented on a specific skill, specific physical exam finding, something that can have an actionable effect on. And then there were these non-specific feedback observations. And these are things like, you asked great questions today, you were really engaged in the surgery today. Something that was a vague observation they really couldn't act on. So when she looked at all the different comments, some of the comments that were encouraging or specific were things like, you did an excellent job providing exposure and identifying anatomic structures of interest in the neck. I tried to go through some workup and preparation of the patient who had Graves' disease with X, who was the student, and he answered the majority of the questions correctly, or was at least providing well thought out logical answers, even though they weren't completely correct. Very specific, talks about Graves' disease, talks about answering questions for the workup. So this is a good quality feedback for the student. Corrective comments would be things like, make sure you start and end the stitch below the dermis and avoid unnecessary harsh handling of the tissue. Corrective things, very specific, very pointed. The student can next time change how they suture the skin together. When she looked at some of the other comments, she classified these as mediocre feedback comments when they had a combination of all things. Follow the directions well, that's a very kind of non-specific, encouraging comment. Understood the basics set up for laparoscopic cases and the challenges of a bariatric airway. That's a specific comment and an encouraging comment as well. And then they talk about ask questions pertinent to the case. This is a very non-specific comments. This is a combination of both. So she would classify those as a mediocre feedback comment from the faculty. She classified ineffective feedback as basically feedback that was completely non-specific. Could be either corrective or encouraging, but if it didn't give the student something to act on, was considered an ineffective feedback. We had a lot of these. Great job, interested and engaged, keep working hard, feel free to ask questions, get involved. Even though that seemed like good feedback for the student, if I was to get this feedback, I don't know what to do with that. Show up tomorrow and do the same thing, I guess. There was tons of these. Will excel in any surgical field, hardworking, engaged, proactive, shows interest, good job, read more. These are the common things that we saw a lot. And then even when they gave corrective comments, it was things that they really couldn't act on. Keep practicing, read more, increase your surgical knowledge base. We saw a lot of these, and then when she looked at all the different comments throughout the entire year, about 60 to 70% of these feedback comments from both faculty and residents across the board fell into these non-specific categories. So certainly we had some work to do, and really we had no idea that the residents and the faculty were giving kind of non-specific feedback to the students. We kind of had a hunch of that, and you can see that in the evaluations at the end of the rotation. But this really allowed us to dive in to some faculty development for the faculty and residents about how to actually give good feedback. To actually use some of the specific comments from the minute feedback system, we presented some of our work at Grand Rounds at in surgery, and really kind of focused in on what it meant to give good specific feedback to the students. We talked about some of the response rates that were different across the different faculty members. And then we basically tried to work on creating a more effective feedback culture, and one that was really open to hearing some of that corrective feedback that was specific for both the students and the residents. The feedback system allowed us to measure those things. It provided more feedback for the students, but really made us realize that we weren't doing a great job with it in the first place.
Dave, I just want to mention that there's a comment in the chat that one of the issues with feedback, non-specific or ineffective, has to do with understanding the student's expectations or the student's understanding of the faculty expectations. Our rotation facilitators try to help by laying out service expectations, but it's hard to reinforce these when we have sporadic contacts with any given student.
Yep, and then I completely echo that comment, and I think setting expectations that the students need to ask for feedback is really important. One of the expectations that we have for them to use this is they have to use it every day that they interact with either a faculty or a resident in the clinical setting. Even though we require them to do that, there's a wide variation of how often the student uses it. Some students use it, 30 or 40 times during the rotation, and some just use it 5 to 10 times. The key with the minute feedback is that it reminds the resident or the faculty to at least feedback to the student something about the particular day. And if the faculty or resident know that it's coming, it makes it a lot easier for them to fill that out at the end of the day. So yeah, I think those expectations are really, really important. So with the experience that we have with the minute feedback system, we've been using it for the past 5 years in surgery. We found that it was pretty useful for our surgery students. And then we started getting some interest outside of medicine. We presented some of our work at some national meetings. Some other medical schools became interested in using it and asked for access to the feedback system. Some other places around the University of Michigan, like the dental school and the nursing school, also were asking for it. Because of the Qualtrics limitations, it made it really hard to share it. So we applied for some grant funding. We got some grant funding to create a minute feedback system that's a standalone product that really is intended to help any educational leads have some kind of platform that allows them to gather feedback from their learners. So this is currently in development. It's not quite ready to use, but we're planning on using it in the dental school and in the undergraduate realm as well. It's just a souped up version of the other minute feedback system, but allows educators to change what questions they ask faculty. It also allows students to change what they ask faculty for feedback about. So that's kind of our experience with the minute feedback system. I'm going to talk a little bit more about some of the other innovative things that we're doing within our own department with feedback in general. So Brian George is an acute care surgeon in the Department of Surgery. His interest is really intraoperative entrustment and the way faculty and residents work during procedures. One of the common complaints that residents have is they don't get entrusted enough. They don't get to do enough of procedures. And the faculty sometimes kind of don't hand over that autonomy to the residents as much as they would like. Dr. George has created this platform called the Simple platform, which focuses in on operative entrustment. And it's a very similar concept to the minute feedback system, where the residents ask the faculty how they did on a certain procedure, how much entrustment that they got using this Weiss scale. And we've been using this in the Department of Surgery for a couple of years, and it's allowed the student or allowed the residents to really focus in on what they can do to have more operative entrustment. Gurjit Sandhu, who's our educational professional in the Department of Surgery, has done some really cool research using some of the data that we have from the feedback system. I just wanted to talk about a few of her research projects because I think they're really important in understanding the disconnect that we have as educators compared to students and residents when they say they don't get enough feedback. One of the studies she did with some of the medical students used the feedback data that we had in the minute feedback system and compared the feedback response of the faculty with their overall teaching quality score that the students gave them at the end of the rotation evaluation. She found that the higher the feedback response rate, the higher the quality teaching score the students gave them. Whether this is related to the students recognizing that faculty that respond to their feedback requests are better teachers, or is it because they're better teachers, they're going to respond to the students more frequently? So certainly there's a little bit of a quid pro quo phenomenon that goes on when it comes to us as faculty responding to students' requests. Gurjeet also did this really interesting study when it looked at interoperative feedback. She had 10 video clips of residents and faculty doing all kinds of different procedures. She had 23 residents and 23 faculty participate in this research study. I was one of those. We watched these videos, and every time a feedback intervention happened during the procedure, the resident or the faculty would timestamp that as a feedback episode. She then surveyed both the residents and the faculty about what they thought they saw during the feedback during the procedures, and then did some statistical and qualitative analysis of this. And really this was looking at the disconnect of how often faculty think we give feedback and how often residents actually perceive that feedback during surgical procedures. One of the main findings of this study was that the faculty recognized feedback during the procedures about 30% more than residents did. Exact same procedure, exact same video that they're watching, just two really different interpretations of that. Some of the qualitative comments I thought were really, really interesting because they really highlight the different point of view that we have as educators compared to people that we're teaching. So some of the questions focused on that faculty were more likely than residents to identify an event as feedback during a particular procedure. This comment hits on it particularly well. This is a resident saying, generally intraoperative teaching is done a lot while specific resident focus feedback is less common. I, as an educator, think those are exactly the same things, but residents clearly see that they're really two different things. This resident said, I most appreciate attending to point out specific actions that I'm either doing well or things I'm doing incorrectly. I would define that as intraoperative teaching. They least appreciate those who take away the instrument without explaining exactly what I'm doing wrong. When you read the faculty comment, it says, typically I will deliver feedback as the case progresses after asking them to perform each task. This is typically verbal to begin with, and if still unclear, I will show them how to perform the task, potentially by taking the instruments away and doing the task themselves, and I find this to be particularly effective. Completely opposite to what the resident would say. They say, I hate when the faculty take the instrument away, where the faculty says, I do it because it's an effective way to give feedback to the resident. She asked a question about nonverbal interactions, maybe identified by feedback by the faculty, but not the residents. The residents had 0 comments that they saw any real nonverbal feedback when they were watching these videos. Whereas faculty said, sure, I give verbal feedback. It's almost nonstop throughout the case. It's really often very specific, but in addition, there's a lot of hands-on feedback. I change the angle of my retraction. I may show the resident how to do the procedure by taking the instruments away and then give them back later on. That nonverbal feedback is really lost on the residents as feedback apparently. And then finally, the residents really want that summative feedback at the very end of the case. They routinely said they want kind of feedback post-operatively when I have time to really digest. And they really want a more big picture strengths or weakness feedback after the case is concluded. Is that because they're too concentrated on doing the procedure that they lose that feedback during the case and they really want some summative feedback at the end? It's really hard to tell. Feedback or faculty, on the other hand, say that I've given feedback throughout the entire operation. Sometimes I try to debrief at the end of the operation, but often I forget. I have other things to do. I've just spent an hour and a half giving that resident feedback about how to remove that gallbladder. I think that should be enough for them, but that's not. Finally, I want to talk about some of the other feedback that we are studying within the Department of Surgery. Jocelyn Vu did a nice study looking at feedback about leadership. She did a qualitative study, and again, Brigitte was heavily involved in this, where they interviewed both faculty and residents about the kind of the culture of feedback within our department. One of the main themes of this was that people just don't really want to criticize each other very much. Even if it's constructive, there's a reluctance to give people negative feedback about their performance, especially when it comes to the way they are leaders within the department. They also felt that the barrier is not really receiving the feedback, but being okay with negative feedback and being okay with people being critical of your performance, as long as it's in a positive light. This revolves around that feeling of really you have to have a growth mindset, and really to concentrate on that feedback that is corrective in order for your own performance to improve. And I've really seen it change with them in the department over the past year or two because of the work that Brigitte has done. One of the resident initiatives that stemmed out of the kind of that day-to-day feedback that they saw the students giving through the Minute Feedback app was for the residents to set goals before they started doing cases with the faculty. And what the residents would do is they would either send emails or they would talk to the faculty before they would start doing a set of cases during the day, and they would set out goals that they wanted to achieve by the end of the day. And at the end of each case, the residents would directly ask the faculty for some feedback or debrief about those goals that they set prior to the procedure. As a faculty, this was kind of jarring at the beginning. They would come to me at the end of the case and say, "What did you think of the things I did today with the goals I set out?" And I always have to remember, what were the goals I set out in the first place? I need to somehow figure out how to give them some constructive feedback at the end of the day when I just spent an hour and a half giving them feedback about the particular case. But if you know it's coming, you can prepare a little bit, and you can really kind of sum up your feedback to the student or the resident at the end of the day. So with some of those experiences, I'm going to talk about some of the faculty development that we've done within the Department of Surgery to try to improve the feedback that we give to both the students and the residents, and how we try to create a culture of feedback based off the data that we've gathered from our own personal experience. So the things we really focus on when we're trying to teach how to give good feedback is it has to be specific. And having those examples in the feedback system to show faculty the feedback that is good versus stuff that's ineffective has been really, really helpful. Giving constructive feedback that's both negative and positive is really, really important. And that timely feedback we also found to be very, very helpful. The residents have kind of built it into the way they interact with the faculty. The students, I think, still feel a little bit of a hierarchical challenge to specifically ask the faculty for feedback verbally. So they're still using the feedback application to really get that constructive and timely feedback. The feedback needs to be relevant, and this is a challenge that we still really struggle with. Even when students are given the opportunity to ask for relevant feedback to them, they often skip that step and just ask for some general feedback about their performance. So we really tried to kind of feed it back to the students that if you want relevant feedback, you need to ask for it specifically. The feedback needs to be actionable, and that really ties back with it being specific and have it be motivating. This has been not something that's been a really big challenge. I think both the students and the residents are always motivated to improve. They really just want that feedback to happen. When faculty ask me, how do you really do that? You know, the students ask me for feedback at the end of the day. I'm often not prepared to give them feedback because I haven't really thought about it. So I refer to this Pendleton model, which the first step is really answer the question with a question. If the student asks for feedback, ask them what they want feedback about. As a factor, that gives me a little bit of time to kind of gather my thoughts. And they'll usually ask for something that's relevant to them. And once they ask for that, it's a lot easier to give them feedback that's going to be relevant for them. Try to pick one strong area and one area that needs improvement. And then really give specific examples from your um, uh, experience with them that day. You've seen them do some patient care in the clinic. You've seen them do some surgical techniques. That's your chance to give them some specific feedback. And then say, you know, next time we work together, let's concentrate on the things that we just talked about. So how do we as educational leads improve feedback in our department? Creating that culture is really important. Providing a framework either with that faculty development in your own department or using something like the Minute Feedback System or some other system that you may have access to. It allows you to measure it. You can label that feedback when it happens. I've gone to saying, you know, I'm going to give you some feedback now about your performance that I saw during the day. That's an easy way for students or residents to really recognize that that's actually happening. And really don't rely on those summative evaluations for feedback. Use those to render judgment and give grades, and try not to give the students and residents surprises on those evaluations. We try to really encourage our learners to seek out and ask for feedback and develop some actionable skills about how to give that feedback. We've got a long way to go in our department. And I think the work that Gurjeet has done has been really helpful with kind of opening our culture to be okay with talking about critical things that people are doing wrong and to give kind of constructive feedback to our learners. So I really want to spend at least 15 or 20 minutes with some open discussion because I think our experience is really different from department to department. So hopefully we could talk more about that.
Thank you so much, Dr. Hughes. And maybe for the discussion part, if people are willing, you might want to turn your cameras back on so it will seem more like a discussion. And maybe some ways that you give feedback that you find helpful or things you need some help on. And feel free to just unmute yourself and ask any question if you want. There is one question in the chat. How do you deal with trainees that perceive their performance higher than it is, and how to give feedback to these particular trainees when they start from a point of feeling accomplished already in a task?
That's a great question. I think setting expectations at the very beginning of the rotation above and beyond what their prior experience is really important. I think the clerkship students come in often really not knowing what they need to do during the rotation. You know, our students started today actually, and I rounded this morning. There was 4 medical students trailing behind the group of 6 other residents, and they clearly were just along for the ride. I hope that our residents are going to go over some of the expectations that they have throughout the rotation to really make sure they understand what they need to do. That feeling of already knowing and already performing well, I think that's our opportunity as educators to find some way to give them some kind of constructive feedback that pushes them even farther into performing well. You know, you don't want to necessarily kind of knock them down a few pegs, but you really need to give them some kind of feedback that can challenge them, I think. And I think that's a big challenge, I think. Does anybody have any suggestions about that?
It's a quiet group. There's a couple more questions in the chat. So One question is a 1-minute feedback app open to all Michigan medicine programs? And if so, how do we get it?
I am working on that. One of the things I've discovered is I know zero about software development and website hosting and things like that. So it's been about a year that I've been working through that with the Academic Innovations group at the University of Michigan. And I'm probably about 2 months away from having it available to everybody. It'll be free to use for anyone within the University of Michigan. So if you are interested in using it in your educational environment, just feel free to reach out to me. And then once it's available, I'd be happy to work with you or one of your educational administrators to help kind of figure out how to use it.
Great. There's another question about the app. Does or will the 1-minute app have the capability for a clerkship director / master educator to give the faculty their own feedback regarding their written feedback comments within the app? For example, highlighting great feedback that would be considered not specific, or ways to improve, more examples of great feedback if the faculty so desired.
Sure. One of the hidden benefits of this, which I never even thought was going to happen in the first place, was that it tracks everything. It keeps everything in a database for you as the educational lead to keep an eye on what's going on in your department, both from the student and the faculty side of things. We have fed back some specific comments to our faculty that they've done. We haven't gone so far to say, hey, all your comments are not really good feedback. This is how you should do better. We've done it more in a kind of a group setting, but you can do whatever you want. I guess it's your prerogative and your relationship with your faculty about how you want to feed that back.
Thank you. Another question from Dr. Greppen. The culture is so important, especially to safety and providing and receiving feedback. You've talked about the culture in various ways, but perhaps comparisons with other departments or schools has highlighted aspects of the culture that really matter in supporting feedback. Any thoughts on that?
Yeah, I mean, culture is hard to change. I'm going to ask Rajit to chime in here too, because Gurjeet has been really, really important within the Department of Surgery to kind of, talking about that growth mindset. We've done a lot of work with both our faculty and residents with the Michigan Promise to talk about emotional intelligence, to talk about being open to kind of corrective feedback. And that's something that is kind of hard to change, but it really has happened because of some of those other things that we've been doing. And Dr. Dimmick has really been leading a lot of those things within our department for faculty development.
Dave, the only thing I'll add is that we've really been able to show that education is a science in the Department of Surgery. And I think elevating it to the same level as outcomes research, basic science, our global surgery, and really seeing it as a credible way to advance our learners, to advance our colleagues, has been instrumental. And that didn't happen overnight. We have amazing surgeons who are also incredible education scientists. And to see that those two can dovetail has been incredibly helpful.
I know that the perception of surgeons is that we're somewhat of maybe a harsh group sometimes, and some of the feedback that we give tends to be a little bit too pointed and direct sometimes. But I really think that that's the hidden benefit, is that we're okay giving some very constructive and actionable feedback, I think sometimes. And I think, some of the students I think are a little bit shocked sometimes when they hear some of that pointed feedback. But I think as educational leads, as long as we kind of reinforce that's coming from a positive direction, that's been one of the biggest challenges. I think one of the biggest helps as well.
Gurjeet needed to leave, but she did say that when folks ask her what it's like to work with surgeons, she says this is what it looks like: collaborative, innovative, amplifying colleagues, and dedicated to doing better. Thanks, Dr. Hughes.
Thanks to Rajit. She's an amazing person.
Anything else? Molly just added to the chat that we mentioned Dr. Dimick. So Doctors Dimick and Walji will present on mentoring next from 11:30 to 12:30. So if you're not signed up for that, but would like to join us, it's the same Zoom link. And so we can put you in the waiting room when this session ends, and then bring you back in for that if you wish to stay on. Any other questions or comments, kind of best practices of what you use for giving feedback?
I'd love to hear some experiences in kind of the outpatient setting. We do a lot of inpatient type of feedback for students, but the outpatient setting is some of a challenge for us too.
So a lot of our feedback actually comes in the outpatient setting. We're the opposite of you. We're more outpatient than inpatient. And we use the Prime Plus model. We just started using it about a year ago. We use it not only with a continuous feedback form in MedHub for the faculty, but also in their evaluations at the end of their MedHub evaluations in the comment section. Probably 50% of our faculty use the form 85 to 95% of the time. And now we're trying to get the fellows now to also use it in the reciprocal fashion. And we've had really good luck with that. We started with the 1 minute preceptor, and it was not widely accepted. But the Prime Plus model seems to, and I'm certain our PD is going to be interested in the 1 minute feedback app.
Yeah, I think we did notice at the beginning, and we went through multiple iterations of the 1 minute feedback, is that we initially included a Likert scale with performance ranking for the student. We almost immediately got rid of that because once the students saw that there was a ranking there, they immediately thought it was associated with their grade, and the usage of the app dropped off precipitously. So we got rid of any of the Likert scale. It's purely formative. We're very kind of specific to the students to say that none of this stuff is going to go on your end of the rotation evaluation. This is just for you to work through the day-to-day interactions that you have. So separating that feedback from the evaluation is really important, I thought.
I like that. I like that aspect of it. And I like that Likert scale is not there. We can't ever agree on what Likert scale to use anyway. So it's nice that that's not even going to be a discussion.
Yeah. I think one of the other challenges that we've had is those end of rotation evaluations. The participation in those really varies from faculty to faculty. And I get a sense that many of the other specialties and departments struggle with the same thing. There's this sense of evaluation fatigue and form fatigue that we all have. And that was one of the main criticisms we've had with the minute feedback system, is it just adds one more thing that the faculty have to do. And I think that's the main reason why about 40% of people just never use it.
Are there any good videos, just as teaching videos, as samples, for example, an outpatient of attending is giving or residents giving good feedback to students? Just sample after sample after sample of good feedback.
Steve, that's a great question. I don't know the answer to that. I know Stanford has some nice videos about kind of like student faculty interactions. It focuses a lot more around mistreatment and getting students involved in the clinical setting. I'm not sure it focuses a lot on feedback though, but that's a great question. I don't know the answer to. All right. I don't know if anyone else has anything to add, Laura?
Yeah, so Naveed says, when I know that a learner will be working with me for a known period of time, for example, 1 week, I ask them what specific thing they want to work on, like a set of personal goals during that period. This way I can direct my feedback and be more specific.
That's great. She may have been listening to Meg's presentation last hour when it comes to coaching. That's really one of those coaching techniques that can be used really, really well. That is really important. The learner has to be engaged, and they have to. I think the best way for them to ask for feedback is ask for something specific. And needless to say, with the Minute Feedback app, it asks them to say something specific they want feedback about, and still only about 50% of them actually do that. Even when you say, please do it, they still don't do it. So I think it's a learned skill, and it takes practice to do that well.
I know Karen Stolberg in a program that she did for us, we talk about when you were scrubbing in for surgery to talk to the trainee then to find out what they wanted to focus on, and so that you could give specific feedback. Just, if you always think to do it at the same time, then it'll become routine.
Yep, that's called I think she's referring to the BID model, which I'm going to butcher it, but I think it's a briefing. It's like a pre-thing, and then I is interaction maybe, and then D is debrief. And the residents do that all the time. It's a bit challenging as a faculty because you have to add that on top of all the work you're already doing. But once you get into more of a routine, it makes it a little bit easier to remember to do that debrief at the end of the case.
Any other final comments or questions for Dr. Hughes? Molly has put an evaluation in the chat, and we'll also send it out following the session. We've been keeping notes on things that our facilitators have mentioned or people have mentioned, and we'll also send some follow-up material after the sessions.
Thanks, Laura, and I'm happy to talk to anybody. Feel free to reach out to me if you want to chat or anything at all.